Every hour a premature baby spends on a ventilator increases their risk of ventilator-induced lung injury. The constant mechanical pressure forces tiny, fragile alveoli to expand, and without precise control, that pressure stretches the tissue until it physically tears. This graphic displays the data gaps in traditional monitoring. On the left, relying only on a physical stethoscope masks the exact pressure levels reaching the lungs. On the right, these illuminated waveforms translate internal lung mechanics into actionable, visible data. Over the next 6 minutes, we will break down exactly how to read these waveforms. We will identify the visual signatures of 5 life-threatening pathologies and apply a 4-step algorithm to troubleshoot a crashing patient. This clinical dashboard uses 2 distinct visual formats. On the left are time-based scalars, which plot a single parameter, like pressure, against time. On the right are mechanics-based loops, which plot 2 different parameters against each other to evaluate overall lung structure. Mastering these visual tools enables proactive lung protection by replacing clinical guesswork with objective, real-time data. This pressure time scalar displays breath anatomy. The curve starts at a baseline floor called PEEP. Pressure hits an absolute ceiling called PIP. The shaded area represents mean airway pressure. A specific downward deflection just before the rise signals the baby triggered the machine. Look at the auto PEEP panel on the far right to see the result of trapped air. Instead of staying flat, the baseline pressure staircases upward with each successive breath, because the baby cannot fully exhale before the next cycle begins. The flow timescaler maps the velocity of air moving in and out. The curve above the 0 line shows the peak inspiratory flow entering the lungs, while the curve below the line shows the peak expiratory flow leaving them. These panels diagnose airway pathologies using flow. The top panel shows an air leak, where the expiratory curve cuts off abruptly. The middle shows bronchospasm, creating a reduced peak and a prolonged expiratory tail dragging out before returning to 0. Pressure and flow scalars provide an immediate early warning system, allowing you to identify timing misalignments and airway resistance issues at a glance. While pressure and flow tell us the machine's settings, we need a separate indicator to confirm those actions are actually reaching the baby's lungs. The volume time scalar serves as the safety net. In a closed system, volume that goes in must come out, meaning the purple triangle must return completely to the 0 line. If the wave stops short of the baseline, gas is lost from the circuit. The left panel shows how volume tracking reveals patient synchrony. Erratic, zigzag peaks indicate the baby is fighting the ventilator. On the right, mapping spontaneous tidal volumes against mandatory breaths proves extubation readiness. Generating sufficient volume during unassisted efforts confirms their respiratory drive. Monitoring volume is the only way to guarantee the ventilator is successfully treating the patient, rather than simply inflating a leaky circuit. To understand the structural limits of the lung, we look at pressure-volume loops. Imagine inflating a balloon inside a rigid glass box. The balloon's material determines stretch, but the glass sets a hard limit. This graphic uses the penguin metaphor for lung compliance. A stiff lung looks like a sleeping penguin, where high pressure yields minimal volume. An optimized lung creates a balanced football shape, while a hypercompliant lung stands tall, showing massive volume shifts with minimal pressure. The over-distension panel on the left shows the visual signature of volutrauma. The top right of the loop flattens into a sharp red beak, signaling that pressure is increasing even though the alveoli have reached their physical capacity and can hold no more volume. Look at the right panel to identify flow starvation. The inspiratory curve scoops deeply inward, crossing itself into a figure 8. This pattern confirms the baby is gasping for air faster than the ventilator is delivering it. The flow volume loop identifies physical blockers. In the leftmost panel, the expiratory curve looks like a jagged sawtooth. These vibrations mean endotracheal secretions are obstructing the airway and must be suctioned immediately. These loops provide the structural blueprint of the lung, revealing whether the tissues are too stiff, overinflated, or physically obstructed. Relying on a single graphic in isolation can lead to the wrong intervention. Safe clinical practice requires cross-referencing data across multiple views. This matrix differentiates an air leak from air trapping, which look similar but require opposite treatments. An air leak causes the volume loop to stop before the baseline, signaling gas loss. Air trapping causes the pressure scaler to staircase upward, signaling dangerous gas retention. This cross-checking habit serves as a diagnostic firewall, preventing incorrect interventions that could worsen the baby's condition. When a monitor alarms and a baby's oxygen levels drop, the natural instinct is to immediately disconnect the circuit. This four-step algorithm provides a way to isolate the root cause, using the graphics on the screen before making physical disconnections. Step 1. Check the pressure scaler to ensure the machine is delivering a breath. Step 2. Verify if volume returns to 0. If the volume wave stops short, the system has an air leak. Step 3. Check if flow returns to 0. If not, the baby is trapping air. Step 4. Look for the jagged serrations that signal the need for suctioning secretions. This ICU diagnostic matrix summarizes every pattern we've covered. Memorizing these visual signatures and their corresponding corrective actions ensures you can respond accurately during your next shift. Deciphering these visual signatures ensures the ventilator provides the objective diagnostic data needed to protect the patient's lungs in real time.